السلام عليكم جميعا. ومساء الخير، وإن شاء الله كلكم تكونوا بخير وعافية. باسم الجمعية البريطانية السودانية لطب الأطفال وصحة الطفولة بنرحب بالجميع. It's just for the sake إنه ممكن يكون في ناس ما بيتكلموا عربي، فأنا I will just go on بالإنجليزي. Okay, sincere welcome to all of you and thank you for attending with us today. And we hope you find this session interesting and beneficial. This is the fourth session in our topics in pediatric emergency series. We had 3 previous sessions so far, and they are all available on our YouTube channel and website page. I'll just give you an idea about how today will be running. Today's session will be around 2.5 hours. We'll try to finish before that if we can, but roughly it will be 2.5 hours. We will have 50 minutes initially for the main talk, which will be delivered by Dr. Inaam, and then it will be followed by 10 minutes for questions. For questions, please write them down in the chat box, and one of our moderators will read them out for Dr. Inaam. If the number of questions exceeds the allocated time, please send your questions to our email, and we will direct it to Dr. Inaam and get back to you with the answer. Our email is info@bsapch.co.uk. After that, we will go for 10 minutes break. Please stay signed in. Please stay signed in because we will be allocating you to the break rooms. After that, we will distribute everybody into 4 break rooms with a moderator for roughly 10 minutes. 2 scenarios will be given to you as a group and will be discussed with the supervision and organization of the room moderator. After the 10 minutes, which will be mainly brainstorming, everybody will be back to the main room and all the cases will be discussed by Dr. Inaam. At the end, we will send you feedback and if you have any comments or questions. Please allow me to introduce our team for today. In the break rooms, Dr. Nada Ibrahim, Dr. Sahar Badr, Dr. Salma Abdullah, and Dr. Salma Amin. And in the main session, moderator is Dr. Isra Bush. The IT will be by Muhammad Abdul Rahman, which is one of the EC members of the BSAPC Executive Committee. He is the secretary of the membership office, and myself. So I think it's time to start now. And I will hand on to Isra, who's going to introduce Dr. Inaam. Isra, the mic is yours, please.
Thank you, Rihab. Good afternoon, everyone. A warm welcome to everyone, and thank you for joining us today. I hope you will find this session enormously useful and exciting. It's my pleasure to introduce our speaker for this afternoon, Dr. Inaam Abdel Hadi. Dr. Abdel Hadi graduated in the University of Khartoum Faculty of Medicine in 1984. She trained in radiology at UCH London between 1988 and 1993. She's currently a consultant radiologist at Darnett Valley Hospital and with subspecialty of chest and pediatric radiology. Dr. Inaam initial talk will be for 50 minutes. And please allow me, Dr. Inaam, to remind you 5 minutes before that. This will be followed by 10 minutes for question. And would you please write them down in the chat? Please allow me to welcome Dr. Inaam. And Dr. Inaam, the floor is yours.
Thank you, Isra. My topic is going to be imaging in neonatal and pediatrics emergencies. I'm going to give you a practical approach, and there will be some workshop at the end of my talk. My talk is mainly going to be non-traumatic with few exceptions. My objective are to review when to image, what is the best imaging modality in neonatal and pediatrics emergency, to review ultrasound uses and limitation in neonatal and pediatrics imaging. I would like to increase your awareness of radiation risk from computed tomography, CT, in pediatric patient and radiation protections. I'm sorry, this is a busy slide, but it's important. I'm going to tell you about the imaging modalities which are available in most hospitals. Conventional and digital radiographs are low radiations, available in emergency and radiology departments, can be performed portably in neonatal special care, emergency department, and ITU. Ultrasound, it does not have any radiation risk, is widely available, can be performed portably in neonatal special care, EDU, emergency department, and ITU. The only problem, it can be operator dependent. Computer tomography, CT scans are available in radiology departments. It is a high radiation examination, may require sedation in neonates and young children. Iodine-based IV contrast is used in some examination for enhancement. Barium and oral contrast studies are available in most hospital radiology department, but in semi-urgent basis. Radioisotope scan, nuclear medicine, and magnetic resonance imaging, MRI, availability dependent on individual departments and hospital, may not be suitable for unwell patients and may require sedation or general anesthesia. I'm going to try to cover the body system going from the top, going down. So I'm going to start with cranial ultrasound. It is useful before the closure of the fontanelle in neonates and infants, can detect subependymal and parenchymal intracranial hemorrhages, some of the structural abnormality and hydrocephalus, not very accurate in the posterior fossa. This is a normal cranial ultrasound. We use the anterior fontanelle and we use a sector transducer. So the top of the head is here, the fontanelle is here, and the posterior fossa is here. We can see the midline, we can see the sulci, we can see the anterior horns of the lateral ventricles, and we can see the third ventricles. As you can see, the posterior fossa is not really well demonstrated. This is, we use it in neonatal units and special care to look for hemorrhage. This is a small subependymal hemorrhage. It's different from the other side. This is the anterior horn of the lateral ventricle. This is the third ventricle. We can stage the hemorrhages. We can follow them up and we can see complications of the hemorrhages. This is dilated lateral ventricles with some hemorrhages here. We can measure the ventricular hemispheric ratio and we can see the progress of the patients. Not every child with a big head has hydrocephalus. Sometimes we encounter this benign enlargement of the subarachnoid space. You can see the ventricles are normal size. The midline is in the middle, but there is excess fluid in the subarachnoid space. This is a benign condition and does not require treatment. I'm going to move to CT scan in emergencies. After the fontanelle close and in some certain setups like trauma, CT is more accurate than any other measuring modality. Like this child who had a fall, you can see there is a large hyperattenuating biconvex lesion in the right parietal region. And if you look here, there is some air in the soft tissues and there is soft tissue swelling. So this is an extradural hematoma. They are usually biconvex. They are arterial bleed from the branches of the meningeal arteries. And the reason it is biconvex is the meninges are attached to the suture. There is marked mass effect and shifting of the midline and compression of the ventricular system. And you can see also we have lost the sulcal pattern indicating raised intracranial pressure. This is a neurosurgical emergency. In this child who is dehydrated and was neurological examination was abnormal. This is an enhanced examination. You can see the superior sagittal sinus is of high attenuation in keeping with sagittal sinus thrombosis, and there is a venous infarct. Sometimes if we are suspecting the diagnosis and we cannot see it on this non-enhanced CT examination, we will give contrast to do a CT venogram that would be more accurate. We also see final sinus thrombosis in patients with meningitis and mastocytitis and other intracranial infections. In this child with abnormal neurological examination, you can see the posterior fossa is abnormal, it's expanded. There is a low attenuation lesion here compared to the brain parenchyma, and there is mass effect on the fourth ventricle. When we see this, sometimes we give contrast, but if there's an MRI to be performed the next day, it will be a better examination because we can know the extent of the lesion and if there is any extent in the meninges and the spine. For the face and the cranial region, lateral cervical radiograph can be used in imaging of the postnasal space, in epiglottitis and retropharyngeal space. Ultrasound is very useful for the soft tissues of the neck and the face, like salivary gland, thyroid gland, lymph nodes, congenital parenchymal cyst. CT is very useful for the complication of acute sinusitis and mastocytitis. Also in retropharyngeal and prevertebral abscesses. This is a lateral neck soft tissue examination. You can see the nasopharynx, you can see the trachea here, and the epiglottis is markedly swollen in keeping with epiglottitis. In this child, you can see the spine. We have lost the normal cervical lordosis. There is widening of the prevertebral soft tissue. The normal soft tissue, the width should be just the width of the normal vertebral body. So this is like 2 or 3 times. And the child has a stridor, and we get a CT scan, and this is with contrast. You can see contrast in the arteries there, and this is a cystic lesion with enhancing rim in keeping with the retropharyngeal abscess, Quincy abscess. We don't have to image in acute sinusitis and mastocytitis unless we suspect there is a complication or the patient has persistent neurological symptoms like headaches. In this child, you can see there is opacification of the frontal sinus. There is a gap here between the frontal sinus and the brain. The bone here looks a little bit thin, and obviously there's a gap, so there is an osteomyelitis. And on the soft tissue, you can see the extension of the infection in the subdural space. This is a subdural empyema. In this child, there is opacification of the maxillary sinuses, more marked on the right. And there is also opacification of the ethmoid air cells. And you can see extension of the infection in the preorbital space in keeping with periorbital cellulitis. The next organ I'm going to discuss is the chest. It is important to know the gestational age and if there is any antenatal diagnosis. Chest X-ray is one of the most commonly requested examination. It is excellent for congenital anomalies, diaphragmatic hernia, like cystic and cystic adenoma malformation. It is really widely used in respiratory distress syndrome in premature newborn. We also use it to locate the lines and the tube, like the endotracheal tubes and nasogastric tubes. We use it in full-term babies and for myocardium aspiration. We use it to see if there's a cardiac disease, used for infection and septic screen. We use it for pneumothoraces and pneumomediastinum. We use it to see if there's a bowel perforation, inhaled or ingested foreign bodies. Ultrasound is very good for pleural effusion, empyema, pericardial effusion, and chest wall soft tissues. And CT can be used for further evaluation in some diagnoses. This is some of the congenital anomalies. You can see this is a neonate. There is a nasogastric tube in situ. There is tubular structures in the left hemithorax. The mediastinum and the cardiac shadow have shifted to the other side. This is a congenital diaphragmatic hernia. Sometimes these are diagnosed antenatally and will require surgical treatment. Unfortunately, even after surgery, there will be some pulmonary hypoplasia and the child lung may not completely recover. This is cystic adenomatous malformation. Again, diaphragmatic hernia is more common on the left side. This is cystic adenomatous malformation. And during pregnancy, fetal examination, this will be fluid filled. Later on, there will be appear like cystic areas filled with air. If they are causing respiratory problem, they will require surgery. And this is another rare complications, rare congenital anomaly, which is nematocele. X-rays are excellent for RDS. You can see the lungs are hyperinflated, they are failing, very ground glass opacities, and you can see air bronchogram. There is a nasogastric tube in situ. Sometimes we can see the complication of treatment, like on this instant, there is a pneumothorax. And sometimes we need decubitus examination if we cannot see the pneumothorax very well. So we do the X-rays with the child lying on his back and the X-ray done horizontal from the side. We also use X-rays of the chest and the abdomen to look for tubes online, endotracheal tube, nasogastric tube, umbilical veins, and catheter tubes. In this child, you can see the tube has curled in the esophagus. They couldn't pass it any further. This is esophageal atresia. However, there is air in the stomach, indicating the presence between a fistula between the distal esophagus and the trachea. This is the commonest type of tracheoesophageal fistula, type C. Also, we use chest X-rays in full-term babies to look for meconium aspiration. Obviously, there will be some staining in the meconium. This is a chemical pneumonitis. The lungs are hyperinflated. There is bronchial wall thickening and patchy areas of consolidation. The lungs will be very stiff, and sometimes we can see pneumothoraces. This is a pneumonia in a young child. Remember, children lungs are not well developed. So sometimes the infection is well confined because the channels between the alveoli has not well developed, and the pneumonia can look like a mass lesion known as rounded pneumonia. You will be guided by the clinical presentation more than the X-rays. If the clinical presentation is suggestive for infection, treat for infection and repeat the X-rays. No need to repeat so closely. We usually allow 4 to 6 weeks if clinically there is no deterioration. In all the children, we see lobar consolidations. It's not important to know which lobe. You can try. It's just better to stick to zones. So you take the 2 first ribs and you say that's the upper zone. You move to 2 more ribs and you say mid zone, and then you go to the lower zones. We also use chest X-rays to look at cardiac problems. In this child, you see there is external suture, so he's had surgery. There is a big heart, there is pleural effusion, and on the echocardiogram, there is pleural effusions and ASD. I would like you to draw your attention that echocardiogram are usually cardiology-led services, not done by radiologists. Pneumothorax and pneumomediastinum chest X-rays are excellent for this. They can be spontaneous. They can be seen in asthmatic and in some syndromes like Marfan syndromes. When you have a tension pneumothorax, the lung will be really hyperinflated and there will be shifting of the mediastinum and the other and to the other side of the chest. In asthmatic, sometimes we see pneumomediastinum, pneumopericardium, and surgical emphysema. This does not require, there is air here in the soft tissue. This does not require intervention if the patient is asymptomatic. It's not, like very unwell from the symptoms. Chest X-rays is very excellent for detection of small amount of perforated intraperitoneal air, provided we can do the examination erect. If we cannot do it erect, we will do a supine abdomen. I would like to talk about foreign body ingestion or inhaler, because children, toddlers, they will usually interact with the world through their oral cavity. So they will put everything in the mouth. Most of the foreign bodies ingested or inhaled are organic and not radio-opaque. One of our worries is the patent batteries, which is widely available, and children usually put it in their mouth, and it got stuck sometimes near the tracheo, in the aortopulmonary window, at the gastroesophageal junction, and in the stomach. We do a chest X-ray lateral to know where is it. So you can see this is the trachea, and the foreign body is actually in the esophagus. The batteries will continue to discharge, and they will form an alkaline solution, which causes necrosis of the mucosa, perforation. This perforation, if it's connected to a blood vessel, the child can bleed to death. So this is a surgical emergency. The ENT team should be considered, should be contacted to remove this. I have heard some very good advice from ENT. If the endoscopy is not going to be done immediately, you can give the child honey at frequent interval to decrease the side effects till the foreign body has removed. Remember, we also children who are autistic or disabled or not communicating, or children with psychological behavior disorders also swallow foreign bodies. We have seen pencils, we have seen for a toothbrush. So just keep your mind open. And if it is, you think it is safe, the parents will look into the feces for the foreign body. If it is not safe, it needs to be removed endoscopically, especially sharp objects, magnets, and patent batteries. Ultrasound is excellent for pleural effusion. This is the liver here, this is the diaphragm, and this is the chest wall. This is the collapsed lung. We can measure the effusion. We can tell the clinician the depth of it if they need to drain it. Sometimes we drain it ourselves. However, in children, it's a little bit difficult because they may require GA or sedation, because it is, even giving the local anesthetic is not well tolerated by some of the children. This is another child. The stomach is here. There is a rim of liver. This is the collapsed lung, but you can see this effusion here is multiloculated, multiseptated, and has lots of pans in it. And this is empyema. If we come across thoracic masses, we used to do lateral examination to know if it is anterior, posterior, or middle mediastinum. Nowadays, we get a CT because a CT will give us an idea about where is this lesion. This is the vertebral body. This is the bronchi, and this is some of the blood vessels. So this is an anterior mediastinal mass, likely to be lymphoma. It was lymphoma. When we see lymphoma, of course, we have to do staging of the neck, chest, and abdo and pelvis. If the child is older, this can be biopsied transcutaneously to get a stage, to know the histology of the lesion. Next, I'm moving to the sorry, I'm just going to solid abdominal organs. Ultrasound is excellent to access organ sizes, focal lesions, and echogenicity of solid organs. Ultrasound is usually the first line of investigation. It's very good for focal lesions in an acute situation like abscesses, biliary dilatation, and gallstones. It is also useful in the urinary tract for congenital anomalies. We use it for UTI, hematuria, glomerulonephritis, pyelonephritis, renal obstruction, renal masses, and urinary retention. In the spleen, we usually look for sides of the spleen, focal lesion, infarctions. Pancreas CT is more superior to ultrasound because if it is obscured by bowel gas, ultrasound is not going to use pancreas very well. So CT is usually used in cases of acute pancreatitis and congenital anomalies. Of course, MRI is better, but MRI may require sedation or GA. Ultrasound can be used to detect pseudocyst if you are suspecting pancreatic duct dilatation or pseudocyst. This is an ultrasound. So the transducer here in the upper abdomen, this is the liver, this is the gallbladder, fluid filled, and all these little white shadows with posterior aqueous shadow, these are gallstones. You can see the common bile duct is dilated. When I was a medical student, they used to say to us, gallstones occur in female, fertile, fat 40. This has changed now. I guess the diet is so imbalanced nowadays. We have seen gallstones in children, and we also see it in children with abnormal hemoglobin, like sickle cell disease and hereditary spherocytosis. We also see focal liver lesions. In this case, this is the liver, the transducers here. There are two lesions here, irregular. This is the larger lesion, this is the smaller lesion. This one has a little bit of septi and echogenic lesions here. This one has more septi here, and this is liver abscesses. Of course, if the child is older and can tolerate a procedure, we can put a small tube and drain it without the need for surgery. Ultrasound is very good to look at the renal tract. Sometimes there are some congenital anomalies detected antenatally, like in this case, you can see the kidney is enlarged and there are several cystic spaces in keeping with a multicystic kidney. We use ultrasound to look at dilated collecting system. This is a bright kidney, slightly bright. The pelvic LCL systems are dilated. The renal pelvis is dilated. The ureter is dilated, and there are echogenic material in keeping with pus or infection. And this is a child with pyelonephritis. Ultrasound is excellent for renal masses. You can see this is the kidney here, the normal kidney. This is the normal renal echo, and there's an echogenic lesion in the lower pole of the kidney, most likely Wilms tumor. The next step will be staging CT scan. I'm going to go to the use of abdominal radiograph in the abdomen. Of course, in the neonate, we use it to look for necrotizing enterocolitis, ingested foreign body. It can be useful in malrotation. We also use it to look at bowel obstruction and perforation. I am an old-fashioned person. I'd like for suspected intussusception to get an abdominal X-ray. It will give me an idea where to look. And even if there is air on the right side of the abdomen, you may have an early intussusception. So the next step will be an ultrasound. We also use abdominal X-ray to look for inflammatory bowel disease. Well, not as a diagnosis, but complication of inflammatory bowel disease. Kidney stones, most of them are radio opaque, so ultrasound is not too bad if we're looking for significant stone. Sorry, CT. I'm so sorry, abdominal X-ray. So this is some of the example of the abdominal X-ray. This is a neonates with dilated loops of bowel. There is air in the loops of wall of the bowel in cases with pneumatosis scoli, and there is air in the portal vein in keeping with portal vein gas in a patient with necrotizing enterocolitis. This is a child with suspected intussusception. Very little air on the right side of the abdomen. There is dilated loop of bowel here, and there is a soft tissue mass, and this is an intussusception, and the next step will be an ultrasound. In children, it's very difficult to say what is large bowel and what is the small bowel, because younger children, because the haustral pattern has not developed yet. But in this case, there is the stomach and there are few dilated loops of bowel, and we don't see bowel in the rectum. So this is distal bowel obstruction. It could be due to stricture, it could be due to Hirschsprung, or even due to imperforated anus. Sometimes we don't get the clinical history, so we have to work it ourselves. We use blend film to look for kidney stone. This is a child with Staghorn calculi bilateral. This is a child with a lot of abnormalities. You see there's a ventricular peritoneal shunt in here. There is a spina bifida. The pelvis looks very small. There is a dislocated hip. So this is a disabled child with neurological problem. This is a lot of stones in a bladder, but from the shape of the bladder, you can see the bladder is elongated. This is a neurogenic bladder with lots of bladder stones. We use ultrasound in the abdomen in a vomiting neonate to look for gastroesophageal reflux, for pyloric stenosis. In malrotation, we may not see the malrotation, but we can see the relationship between the superior mesenteric artery and vein, just to give us an indication. We use ultrasound for appendicitis, intussusception, inflammatory small bowel disease, duplication cysts, abdominal wall, and groin hernias. These are some of the examples. If we are suspecting pyloric stenosis, usually we give a child a feed, preferably water. There is the stomach, there is a liver, there is the stomach here, and you can see the water is against the pylorus, which is elongated, thick wall, and this is pyloric stenosis. This is intussusception. You can see the target sign or pseudo kidney sign or donut sign, you call it what you like, but it is a loop of bowel within a loop of bowel. If there is no history of peritonitis, no suspicious of peritonitis or perforation, we can even attempt to reduce this using barium, water, or air in the radiology department. This is appendicitis. So we look for the appendicitis in the right iliac fossa. If the appendix is inflamed, it will be thick wall, not compressible, and very tender when you apply tenderness to it. We don't always find the appendix if it is lower down in the pelvis, if it's retrocecal, or if there is malrotation, appendix is not going to be in the right iliac fossa, but we may see other signs of inflammation like an abscess or fluid collections. Barium examinations are usually not done urgently, but semi-urgently. You will be able to get it the next day. So this is a child, a vomiting child, nasogastric tube in situ. This is the stomach, the duodenum, and this is the duodenum, and you can see it does not cross to the other side. And then the duodenum is going in this corkscrew. So this is malrotation with midgut volvulus. This is a child with antenatal diagnosis. There was polyhydramnios, and they could see double pupil appearances on the ultrasound of the fetus. So they did an X-ray to confirm, and of course, there is a dilated stomach, a dilated viscous, and no distal air. It could be many causes. It could be duodenal atresia, duodenal web. It could be intrinsic or extrinsic. And sometimes we do barium just to see if it's going through, it more suggestive of extrinsic compression. Be aware this can be seen in some congenital anomalies and abnormal syndromes. So look for other syndromes. Whenever you see bowel anomaly, look for abnormality in the vertebral bodies, fatter or factual. This is ulcerative colitis, barium enema. You can see the colon is very smooth. It lost the haustral button. This is an older child. The mucosa is irregular. So this is a continuous inflammatory process from the rectum all the way to the other side in keeping with ulcerative colitis. CT is useful in some examination. The urologists now, they like to do non-contrast low dose CT examination to look for renal stones. It is very good to locate the site of the perforation and obstruction. So most surgeons are not going to go to theater unless they have like a roadmap to tell them where is it likely to be. Enhanced examination in the arterial phase is also useful for bowel ischemia. We use CT if there's sepsis and we don't know where is the source of the sepsis, so CT can be useful. Also for postoperative complication and image of vascular anomalies like vasculitis. I didn't include many CT images, but when you see a cystic or solid lesions, ultrasound may not be able to tell you where is it coming from. So you will need a CT scan just to give you like anatomical delineation. In this case, this was a foregut duplication cyst. Ultrasound is excellent for assessment of the female pelvis. We use it for pelvic masses, ambiguous genitalia, pelvic and period pain, irregular periods, precocious puberty, amenorrhea, concealed pregnancy, and vaginal discharges. This is a teenager who had no periods, but she presented with lower abdominal pain and periodic abdominal pain. And this is the ultrasound. We just do transabdominal examination in these children. So this is the abdominal wall here. This is the bladder. And there is this elongated viscous here. This is longitudinal scan. This is transverse scan. And it has echoes within it. And there's a small tract in here. So this is a very dilated cervix with blood product, and air is going in the endometrial cavity. This is a hematocolpus or hematometria colpus, usually due to imperforated hymen or vaginal septum. This is the left ovary, and you can see the right ovary is enlarged. You can see the normal follicle distribution on this ovary. In this ovary, not many ovary follicles are present, and some of them are in the periphery, nothing in the middle. This is ovarian torsion, another emergencies. We can have a look at the blood supply by Doppler, but it's not usually very accurate because the ovary receives two blood supply, one from the ovarian artery, one from uterine artery, and also torsion can be intermittent. Ultrasound is very good for ovarian cyst. This is an ovarian cyst, and you can see it is very bright with some bright echoes. And there is some acoustic tissues, acoustic shadow from this calcification. Sometimes we can see a tooth or a whole set of teeth, and this is fat in a dermoid cyst. Occasionally, we get surprises. We can see concealed pregnancy or even an ectopic pregnancy. This is one of the best times for the operator to pretend they don't know what they're looking at. If possible, go get another pair of eyes, confirm viability, confirm gestational age, how far it is, and then we need multi-team approach, including social services, because you don't know what is the background, if there is child abuse, if there's rape. So, and it's in some cultures and communities, this has serious consequences. Testes and scrotum ultrasound is best investigation for epididymitis and epididymitis, for torsion, hydrocele, scrotal, and testicular masses. This is the left testis, and you can see this is the normal echogenicity of the testis, and there is this low attenuation area here, slightly darker than the rest of the tissue. And when you put the Doppler, there is an inflammatory circulation in keeping with orchitis. Torsion, ultrasound is not 100% accurate. If you suspect torsion, get a surgical opinion. In the first 6 hours, you are likely to save 100% of the testes. 6 to 12 hours, you will save about 50% of the population testes. 12 to 24 hours, you are only going to save 20% at presentation. So if you think there is torsion, get a surgical opinion. If the surgeon is convinced, he may not even get an ultrasound. Ultrasound is very good for hydrocele. This is the normal testis. This is the spermatic cord, and this is fluid in the scrotum in keeping with hydrocele. Ultrasound also useful for testicular malignancy and masses. This is an enlarged testis with several ill-defined hypoechoic and then small foci of calcification in this child with a testicular mass, and this is turned out to be a seminoma. Plain radiographs are the bread and butters of bones and joint. They are usually the first examination. They are used in suspected trauma and fractures, joint location, in Perses disease, slip femoral epiphysis, osteomyelitis, for soft tissues and bony masses, and also in arthritis. This is a young child. Usually this presentation is more common in boys between 5 to 8 years old. The good thing about the pelvis, you have two sides to compare. If you look at the femoral epiphysis here, it is slightly sclerotic compared to the other side. There is widening of the epiphyseal line and fragmentaceous. This is femoral heads from necrosis, Perses disease. We see it in patients who also on steroids and sickle cell disease and other things which are not very common in Sudan, like Gaucher disease. This is another child with a painful hip, slightly older. This condition also, again, more common on boys, usually 10 to 17 years old. Same thing for the pelvis. It is useful to examine if you are suspecting this condition, which is slip femoral epiphysis. It is useful to get a frog lateral and compare the two sides. So this is the normal alignment of the femoral epiphysis here. On this side, you can see there is widening of the epiphyseal plate, and the femoral epiphysis has slipped down a little bit. 20% are bilateral, so that's sometimes not very helpful if it's very early. In this child with painful wrist, you can see there is a periosteal reaction. There is rarefaction of the bone in the radial head. The epiphysis has not fused, so this is a younger child, and this is localized osteomyelitis secondary to Brod's abscess. Musculoskeletal ultrasound is very useful in several conditions, including neonatal hip dislocation, torticollis, hip pain, muscle, tendon, and ligamentous injury, inflammation of the joint, joint effusion, and bursitis, early changes in rheumatoid arthritis, soft tissue lesions, and foreign body in soft tissues. Some of the sophisticated MSC conditions like ligamentous injury are done by specialized radiologists and sonographers. So this is, you can see this is the hip joint here in a child with an irritable hip. This is the ilium here, and there is joint diffusion. And in this child with a non-juvenile arthritis, there is a Baker cyst behind the knee containing fluid, and there is the joint, the connection to the joint space. This is one of the major traumas. You know, we don't like to see it, but it's a fact. Some communities do not believe we have it. I think in Sudan, we didn't think, a lot of people think we don't have it. We have it. We may call it something else. We may call it discipline, but this is a serious condition. This is a child with several rib fractures, and you can see some of the fractures are healing. Some of them on this X-ray here, they are acute. So the fractures are at different ages. We do a skeletal survey, and they are fracture of the radius and the ulna, and they are also metaphyseal fracture. So this is a non-accidental injury, and this has serious consequences for everyone. And every hospital has a team to deal with this, and it is usually a multi-team approach. I'm going to talk about pediatric COVID since we are still on and off COVID situations. So most children, when they get acute COVID, they are less seriously affected compared to the adults. However, there is this rare syndrome, which is a multi-system inflammatory syndrome, which is a rare complication of COVID. Imaging is not specific. In chest X-rays, you will see consolidation and atelectasis. On abdominal ultrasound, you will see hepatosplenomegaly, ascites, enlarged lymph nodes, bowel wall thickening, echogenic kidneys due to acute kidney injury. Most of the time, the neurological imaging is normal. The mimics are Kawasaki disease and toxic shock syndrome. So this is the chest X-ray of a child with multi-system inflammatory disease. You can see the heart is enlarged, so he may have some pericardial involvement like pericarditis or pericardial effusion. They are bilateral consolidation and atelectasis. We don't see the diaphragm very well, so there will be some effusion. We do the abdominal X-ray, abdominal ultrasound. The liver is enlarged, is going in front of the kidney. The kidney is here. There is fluid in front of the liver and also in the hepatorenal fossa. In this child with renal failure during this syndrome, you can see the kidney is echogenic compared to the liver, and this is interstitial renal disease. As I said, this is not specific to COVID, but this is some of the imaging presentations in this condition. Although ultrasound is brilliant, it does not use radiation. It is operator dependent. So also, we don't like obese patient, and it doesn't see organs and viscera, which is filled with air. So we are not going to see the lungs unless there's an effusion. We may have an indication there is a small pneumothorax, but chest X-ray does much better on this examination. Again, the bones will absorb the sound wave. So we are not going to see the inside the bones. We are only going to see the surface of the bone.
Uh, 5 minutes to go, Dr. Inaam.
Okay, thank you. I'm almost done. Finally, I would like to bring your attention to this international campaign, which is called Image Gently and Image Wisely. Ionizing radiation is used to create many of the images necessary for detection and diagnosis and management of injury and diseases on today's examination. One CT scan is equivalent to 100 X-rays. So collimation, lead protection are essential during most of the examination, especially for the genitalia. If the child, a female child, is menstruating, it's important to give the radiology department the last menstrual period. CT is one of the most commonly used cross-sectional imaging tools nowadays. Radiation dose to the patient should be considered and on every examination. Children are considerably more sensitive to radiation than adults. The risk of developing radiation-related cancer is higher in children. Collaboration between medical teams is essential to choose the best and the most appropriate imaging modality to confirm the diagnosis. Everyone should ask themselves, can I do this without a CT? Can I do a low dose examination? Will it give me the answer? Every department should have a protocol for children, what dose to use, and what to, try just to examine the region of interest if possible. And also, if you're using contrast examination, intravenous contrast examination, the dose should be adjusted to the child weight. These are my references. I must say, the second reference is really, really good. I think it's an Australian website. It's really good for teaching and learning radiology. Thank you for your attention.
Thank you very much, Dr. Inaam. Nice presentation. And now we are going to start the question. I'll just start with the first question. Why ultrasound is the best in detecting hip dislocation?
Before the age of 6 months, the femoral epiphysis is not ossified, so you're not going to see it on X-rays, but you will see it on ultrasound.
Okay, fair enough. Now we have another question. If minimum pneumothorax can be detected by lateral X-ray, left or right is a good decision, is a good choice. Let me say it again. If minimum pneumothorax can be detected, by lateral X-ray, left or right is a good choice.
Any side, it doesn't matter as long as the child is lying supine for a while. So if the child was in the prone position, we will tend them supine for a while just to allow the air to raise up to the anterior lung surface. It doesn't matter which side you use. You just use a lateral exposure.
Okay. So there is another question regarding MRI. We're facing some problem with T1 and T2. They want like a simple explanation about that.
Okay. You don't have to worry about the sequences unless you're a radiologist. Basically, T1, if you're in an exam situation and you want to know the sequences, if it is labeled, of course, that's a bonus. If it is not labeled, look for the nearest structure which can contain fluid. It can be the bladder. If the bladder is dark, that's a T1 sequence. If the bladder is white, bright, that's a T2 sequence. In general, there are a lot of sequences, and most machine now, they will tell you what sequence is that. Because even within T1 sequences, there are some variations.
Okay, thank you very much for that. The next question is, what is the difference between hemorrhage and ischemia appearance between CT and MRI, and also the localization of organs?
The localization of organ is the same in both of them. Hemorrhage, we use CT for hemorrhage, especially in the acute situation. MRI is not suitable for unwell child. You may need sedation or general anesthesia. Not all ultrasound, you can monitor a very ill child. So I wouldn't use MRI in the acute situation. MRI can detect smaller hemorrhages, but you need the patient to be really still to do. The sequences are long. Any sequence in ultrasound, even if they shorten it, is many minutes, 3 to 4 minutes. So it's not suitable for a very unwell child.
Okay, thank you. The other question is, can we see hip dislocation after 6 months in X-ray?
Yes, we can, absolutely.
Okay, that's fine. And the other question is, how can you know if there is peribronchial thickening or fibrosis in X-ray?
Okay, in the acute situation, in most viral infection, most of the changes in viral infection are usually peribronchial thickening and cupping. This is in the acute situation. If the symptoms are persistent and you think there is fibrosis, you have to get a CT scan, because chest X-ray is not going to tell you. There are several types of fibrosis, and chest X-ray is not going to tell you what type of fibrosis you are dealing with.
Thank you very much. The next question is, which is better to detect chest congenital malformation, CT with or without contrast?
Depends on the suspected congenital anomaly. Like, for example, for diaphragmatic hernia, we don't need to give contrast. We can just do a low dose. All we want to know to confirm the presence of bowel in the presence of the bowel in the chest wall. If you are suspecting like scimitar syndrome and you want to see the blood supply to where is it coming from? Is it from above or below the diaphragm? You have to do an arterial examination because you want to know the vascular arteriality which is supplying the area.
Okay, thank you very much, Dr. Inaam. The next question is like a comment, and I think he needs your opinion. I have read recent guidelines recommend not to perform head CT for concussion. So what do you think about that?
That's where are the guidelines from?
Yeah, good question.
I think now we are in a medical legal world, and most clinicians will have no leg to stand for if something is missed in a child with a concussion. You do not know what is causing the concussion. Unless the child is well, then you can wait and observe and decide to image later. But depending on the clinical situation, if you think the child is seriously ill, I will get a CT scan.
Okay, I hope this the correct answer for you, whoever asked this question. The other question is, what is your experience regarding giving glucagon for esophageal foreign bodies?
I must say I haven't come across it. It depends on the foreign body. Our surgeons, if the foreign body is sharp, if it is like a foreign magnet, or if it is like a button battery, they usually remove it. If it is a coin or something, you know, like a toy or something, it can be the movement within the foreign body can be followed by x-rays. And we usually ask the mother to look in the feces. Not a nice job, but has to be done. So it depends on the type of the foreign body. Button batteries, they have to be removed. Magnet, they have to be removed. Because if the magnets, small magnets, are in different loops, the loops will stuck together, the magnet will stick together, and they're not going to move. We have seen in children with abnormal social behaviors, we have seen some people, they have razors and needles and other things. So these sharp objects, they will cause damage and they will have to be removed.
Mm-hmm. Thank you very much. The next question is, want to suspect there is valvuloureteric junction stenosis by ultrasound.
Okay, ultrasound is not a functional examination. So you will see a dilated pelvis. you may not see the ureter, but that does not say the ureter is not functioning or obstructed. For pulmonary junction obstruction, you will need a dynamic examination, and radioisotope scan are excellent for that.
Thank you very much. There is another question. What is chest X-ray finding in asthma rather than hyperinflation?
Hyperinflation and like a pigeon chest, you know, like the ribs will be really big. And if there's an added infection, of course, you're going to see added infection. If there's a complicated complication of a pneumothorax, pneumomediastinum, you will see, but it's not very specific diagnosis. I cannot just say this is asthma. I will just say the lungs are hyperinflated, query asthmatic. You're never 100% sure.
Okay, thank you very much. This is a nice question. If there is super fast MRI for children?
Not everywhere. If you live in America, yes. Ultrasound MRI machines are very expensive, and not everyone can afford these new inventions.
Thank you. The other question is your experience in orbital ultrasound to diagnose ICP?
It's usually done by the ophthalmologist. I personally haven't done it. Actually, to do ultrasound even of the head and neck in children, if you know, like infants, it's not very easy. So I imagine they may have to give them sedation if they are using the intraorbital ultrasound to look at raised intracranial pressure.
Okay. For status epilepticus, do you think CT brain might be useful?
Only if you are suspecting head injury or bleeding. If you are looking for anomalies like mesial temporal sclerosis, MRI is examination of choice.
Okay. This is the last question. In fact, there is no air in the fetus. If air occurs, the fetus is dead. In fact, there is a proper statement is gastric vesicle.
So the baby is fetal death?
It seems like this because he written if air occurs, the fetus is dead.
Where is the air though? Can we just have a little bit more information?
This is the question. In fact, there is proper statement is gastric vesicles. I think we can move to the last question. If pneumothorax is in left side, shall we request a lateral, left lateral X-ray for more clarification?
It depends on the pneumothorax. If it's in neonates and you are going to drain it and you need more information, yes. If the pneumothorax is asymptomatic, like incidental finding, and you are going to treat it conservatively, and you can see it on the AP examination, you don't need to do any more further tests.
Okay, thank you very much, Dr. Inaam. I think by this we came to the 10 minutes questions, and we end the session now for a break for another 10 minutes. Thank you very much, Dr. Inaam, for your talk.
Thank you.
Joining us this afternoon.
Okay, so we will go now for 10 minutes break. Please stay signed in, don't log out. After you come back, we will be distributing everybody for the workshops. So if we come back at 20 past, at 3:20. Okay, see you.
نحن أسود الغاب أبناء الحروب، لا نهاب الموت أو نخشى الخطوب، نحفظ السودان في هذه القلوب، نفتديه من شمال أو جنوب، بالكفاح المر والعزم المتين، وقلوب من حديد لا تلين، نهزم الشر ونجلي الغاصبين، كنسور الجو أو أسد العرين، ندفع الردى نصد من عدا، ندفع الردى نصد من عدا. نحن جند الله جند الوطن، إن دعا داعي الفداء لم نخن، نتحدى الموت عند المحن، نشتري المجد بأغلى ثمن، هذه الأرض لنا فليعش سوداننا علما بين الأمم، يا بني السودان هذا رمزكم، يحمل العبء ويحمي أرضكم.
السلام عليكم ورحمة الله وبركاته. اليوم في الفيديو ده حنكلمكم بشكل مختصر عن الجمعية البريطانية السودانية لطب وصحة الطفل، اللي هي British Sudanese Association of Pediatrics and Child Health، أو اختصاراً BSAPCH. هل عندكم فكرة عن الجمعية دي؟ طيب، للناس اللي ما عندها فكرة، هي جمعية خيرية غير ربحية وتعليمية، تم تكوينها في المملكة المتحدة سنة 2003، يعني لها زي 17 سنة. من أهم الأهداف اللي قامت على أساس الجمعية دي هي دعم وتنسيق الجهود للنهوض بخدمات الطفل في وطننا السودان، طبعاً بالإضافة للمساهمة في دعم الحالات الإنسانية بشكل عام في السودان. وبالنسبة للأعضاء، فالجمعية تهدف إنه تساعدهم في تطوير نفسهم أكاديمياً ومهنياً. الجمعية وبجهود أعضائها قدرت تحقق بعض الإنجازات في الفترة الماضية، على سبيل المثال التعاون المستمر مع جمعية الأطفال السودانية ودعمها في عدة مجالات، أبرزها الدعم المادي والعيني، وإمدادات لوجستية كأجهزة الحاسوب والبروجيكتور والمانيكانات التي تستعمل في كورسات الإنعاش الرئوي، دعم فريق طبي متخصص في علاج أورام الأطفال من مستشفى نوتنغهام، وتقديم دورات تدريبية مكثفة في مراكز علاج السرطان في السودان، إمدادات طبية متواصلة زي معدات السلامة للأطباء العاملين في الخطوط الأمامية في جائحة الكورونا، تقديم المحاضرات وورش العمل، والمساهمة في مؤتمرات جمعية الأطفال العلمية. الجمعية بالتأكيد حتكون الممثل لكل المختصين والمهتمين بصحة الطفولة، وحتكون فرصة طيبة نطور فيها اهتماماتنا المشتركة ونتواصل من خلالها. الفيديو ده دعوة لكل المهتمين بصحة الطفل في المملكة المتحدة وجمهورية إيرلندا للانضمام للجمعية والمساهمة في تفعيل نشاطها من جديد، والخدمة في برامجها لتقوم بدورها الأكمل لتحقيق أهدافها. ندعوكم لزيارة موقعنا على الإنترنت اللي حيظهر على الشاشة وتعبئة فورم التسجيل، وكمان موجودين على مواقع التواصل الاجتماعي اللي حتظهر على الشاشة برضو. شكرا كثير على المتابعة، وزي ما دايما بنقول، سوا أكيد بنقدر. Okay, so I think it's 10 minutes break is already time to start the workshop. I think all our moderators are here. So I'll be moving everybody to the workshops now, and moderators, please, as agreed, just make sure you are in the correct room. And once you are there, just go ahead and straight away start, okay?
Yes, I can, of course.
Okay, so welcome back, everyone. So in the next 40 minutes, Dr. Inaam will go through the workshop cases. I will just remind you 10 minutes before the time is over. We will start with case by case, group number 1.
So
Yes.
who was the representative for room number 1? Was there any representative to go through the case with Dr. Inaam?
Yeah, we have two representatives. Yeah, one for case
Good.
1 and one for case 2.
Brilliant. Okay, so let's start with the first case, please.
yes. So I'm Melka. I'll be presenting case 1 from room 1. This is a newborn male baby who presented with crying when passing urine and a weak urine stream. The question was, what is the initial investigation? Yes, so what imaging would you request? And that was an abdominal ultrasound, and it showed a dilated pelvis, calyces, urinary bladder, and a hydroureter. The next question was, what is the next useful investigation? Which was an MCUG. And the MCUG showed a constriction in the urethra, which led us to the diagnosis of a posterior urethral valve. Yeah, so it showed dilated ureters. Okay, so the diagnosis is a posterior urethral valve, and the treatment was ablation.
Can you just go back to the ultrasound, please? So yes, excellent, well done. And I didn't show the other kidney, but there was bilateral renal pelvis dilatation, the collecting system is dilated, the ureter is dilated, the bladder is dilated. More importantly, the posterior urethra is also dilated. Okay, so we are suspecting posterior urethral valve. Some of these cases are diagnosed antenatally. There will be oligohydramnios because the child is not passing urine, so there will be not enough fluid in the amniotic fluid. Can you show the MCUG, please? So the MCUG, we do it by putting a nasogastric tube in the urinary bladder. We fill the urinary bladder, and you see the contrast has reflected into dilated ureter. This ureter is tortuous, both of them. The renal pelvises are dilated, and there is some reflux into the renal parenchyma. This is the grade 4 vasculoureteric reflux. On the lateral examination, it is not this stricture we're looking for. It is the dilated posterior urethra, and there is this line here that the posterior valve. The reason it is lying against the wall, because when we put the NG tube, we pushed it. When the child starts micturating, it will come down and form a web like it will, urine will not go through it or can go through it in a small amount. So this is, as you said, treated by resection. There are some papers of people doing this in utero. They can release the obstruction by putting like a suprapubic catheter or doing a nephrostomy, putting a tube in the kidney just to stop to release the pressure, but this is controversial and it's not widely available. Excellent, thank you.
Thank you.
You can go to the next case.
Hello. So this is Jihan. I will present this case. This is 3 years old child who presented with sudden cough, choking, and wheeze episode. So what is your suspected diagnosis? I think with this age group, if we have this acute history in fit and well child, we will suspect foreign body inhalation. And at the time, we'll examine the child and we will request chest X-ray. And I think this is what has been done. Next slide.
Can we see the chest X-ray?
Matt, can you put the case again?
Sorry for that.
No problem.
Just go to case 2.
I can see the X-ray.
Here.
Thank you.
Okay.
So, from the first look to the X-ray, I feel like the left lung is more expanded than the right lung. And I can see like the volume of the right lung is smaller than the left one. But I can see any specific area of consolidation or like no consolidation or no collapse, focal collapse in this X-ray. As we know, like most of the foreign body will be like radiolucent, so I can't see myself any foreign body in this chest X-ray, but also I can't exclude foreign body inhalation based on this X-ray. So I think the next step will be to inform the ENT doctors, so we can request a bronchoscopy, and to see if there is any foreign body under like something under vision. This is my impression.
Thank you. It is not possible in young children to obtain chest X-ray on expiration, because if we obtain chest X-ray on expiration, it will be ideal to see if there is air trapping. So excellent, you have compared the two sides. The left lung is hyperinflated, the diaphragm is flat, and you can see there is widening of the intercostal space compared to the right. That's the normal lung. This is the abnormal lung. This is emphysema secondary to foreign body. We don't always see the foreign body. The majority of the foreign body, which is big enough to go in trachea and the bronchial tree, are small, so they tend to be peanuts or something. We are not organic. We are not going to see an X-ray. If the diagnosis is suspected, it's an emergency, and bronchoscopy is the better examination. What side is usually common? Sorry, I didn't get your name.
Right side.
Why?
Just I think because the position of the bronchus is more straight, so everything can go quickly to the right side.
Yeah, the right bronchus is slightly wider than the left, and it has less angle of diversion compared to the left. So like it's a continuation of the bronchus. So they are very, very well done. Good analysis.
Sorry, I just have a question, when we can suspect seeing any reaction to this foreign body, if it's like a peanut or things on the lung on the X-ray, because sometimes it'd be like reaction from the lung on inhalation of specific foreign bodies.
Not on the acute phases. You are not going to see anything on the acute phases. Later on, when they start have build of secretions, you will see some reactions, but not in the acute phase.
Okay.
And a normal chest X-ray does not exclude a foreign body. If it's this diagnosis is clinically suspected, it is better to raise the alarm and get the ENT team to have a look, or the chest team.
Okay, thank you, Inaam. Now we will move to room number 2. Case number 3.
Yes, I'm Hajar. I'm going to present the case. An 18-month-old child presented with episodic abdominal pain, off foot, crying, swollen stomach. He was pale, dehydrated, distended abdomen, palpable sausage-like mass in the right side of the abdomen. The questions were how you are going to manage this child. First, we will stabilize the patient, ABCDs, and if shock, we'll give him normal saline, and we will put a free drainage NG tube. And the other question, would you like to request any imaging? Yes, abdominal X-ray. It showed dilated bowels, mainly to the right side. There is no air almost on the, on the left side, there is no air or dilated on the left side. And I can't see air in the rectum also. And so that was my comment. There is no air in the diaphragm. I don't know if there is anything to add. And the other question, what is the next investigation? It is abdominal ultrasound to confirm the diagnosis. Here we can see double circles, or as we can see, a donut sign, which will be consistent with the intussusception mainly. So what can you see, and what is your diagnosis? Intussusception. How do you treat this condition? Either air reduction or contrast reduction. And if failed, then we will go for surgical correction.
Very good.
Thank you.
So the X-ray confirmed there's a nasogastric tube because the child is vomiting and not very well, dilated lobes of bowel, very little air on this side, just apart from this area, and an impression of a soft tissue lesion. And the next step is to do an ultrasound.
Yes, yes.
Can we have the next image, please? So the ultrasound confirmed the presence of a target lesion. It looks like a, shooting targets or a donuts. There is bowel within bowel and the small bowel obstruction. So this is intussusception. If the history is acute, there is no sign of perforation or peritonitis, we will attempt reduction, ideally with air. It can be done also in ultrasound with water and with fluoroscopy with barium. If attempting barium, most people will have 3 attempts, because if you perforate the bowel with a barium leak in the peritoneum, it is a toxic peritonitis, so it's quite dangerous. So I will not attempt a barium unless there is a pediatric surgery team nearby or easily reachable.
Okay. Okay. Thank you very much. Now to case number 4.
Sorry, is it happening in the theater room or in the radiology department?
In the radiology department.
Yeah. Which one, the barium one or the air?
All of them. And
okay.
actually, like if the child is very distressed, we will sedate the child, but most of the time we need to sedate the parents, because the child is okay, the parents are very stressed.
Anxious, yeah.
So moving to case number 4. Who's going to present room 2? Case number 4.
I don't know if she went out. Who was taking care of the case of the sickle cell?
We'll give it to the moderator.
Well, go ahead.
Yeah. Yeah, Sana Rashwan. Sana, if you can just unmute yourself.
Yeah, hi, sorry, I'm just having some noise around me. So yeah, this is a child with a history of sickle cell disease, and he presented with pain in his fingers and also chest shortness of breath. So we requested for him chest X-ray and hand X-ray as well.
What is the finding, Sana, in the hand?
Yeah, so there is some swelling of the soft tissue and apparent necrosis in the fifth finger. And chest X-ray, I think there is some abnormalities in the vertebra with the narrowing of intervertebral space, but I cannot comment on the humerus. It's not apparent here in the chest X-ray.
Okay, fair enough. Can we go back to the hand X-ray, please? So the hand X-ray, if you look at the metacarpal, most of them are abnormal. For example, this one here, it has a periosteal reaction. This one here is expanded. There is an ill-defined lucent area. There is another lucent area here with some abnormal trabeculae. So this is dactylitis and osteomyelitis, which is a common complication of end arthritis in sickle cell disease. Can we go to the chest X-ray? Chest X-ray, big heart, chronic anemia. So the heart is enlarged. Sometimes we see consolidation and crisis and things like that, but this is the lung are clear. If you look at the femoral head, this femoral head is a little bit sclerotic, slightly denser, and this is avascular necrosis in the femoral head. If you look at the vertebral bodies, they are not square. Kind of, there is a dip in the middle. So this is end arthritis, and the vertebra will be H-shaped due to avascular necrosis. There's an ultrasound as well, isn't it? No? I didn't give ultrasound?
Yeah, there is.
Okay, then.
There was no ultrasound.
Okay, there's no ultrasound.
Just
Yeah.
request,
So,
yeah,
yeah.
just-
So if the patient has abdominal pain, we will look for gallstones and we'll look for splenic infarctions.
Sorry, Dr. Anam.
Yes.
Do we have some sort of mild pneumopericardium or pneumoperitoneum? Mediastinum, just X-ray or no?
Okay, not really. You looking at this here? This is air fluid level in the stomach, and the next bit of air. You can tell here that the spleen is small because look at the colon, how it is gone. So these people, they get splenic infarction, so the splenic become very small. So the splenic flexure is a little bit high, giving you this, maybe there's a pneumoperitoneum. I don't think so. So
No,
on the other side?
Yeah, I mean pneumopericardium or pneumomediastinum.
Not really. Yeah, I know you're looking at this, aren't you, here? Yeah, no, it's just big heart, which is like heart failure from chronic anemia.
Thank you.
Thank you very much. Now we are going to move to room number 3 with case number 5. Who's presenting?
Ana Wafa. So this is a teenager who has long-standing history of productive cough, presented with chest pain and shortness of breath. His blood test showed raised inflammatory markers coupled with abnormal liver function. What would be your next radiological investigation? It's X-ray. Sorry. So the X-ray had showed like bilateral patchy changes with evidence of hyperinflation and right-sided pneumothorax, no evidence of tension pneumothorax. And the ultrasound had showed a hyperechoic liver compared to the renal, so maybe indicative of hepatitis or liver inflammation.
Okay, good. So we can go back to the chest X-ray, please. So the chest X-ray, the lungs are hyperinflated. There is, as you correctly pointed, there is a pneumothorax. There are, you can see these ring shadows, which is bronchial wall thickening seen end on, and they are thick.
Dr. Inaam, we cannot see. You don't have arrow.
Sorry?
We cannot see. You don't have pointer.
You don't have a monitor. Okay, then.
Pointer.
Okay, I'm so sorry. Okay, then.
Okay.
I don't know what I'm going to do about this. Maybe you can point it yourself, no?
I'm not sharing the screen.
I am.
He- the-
Okay, let me see. No, no, I lost you.
Oh, really?
No, because you are sharing it from my end. I don't have the slides.
It's being shared by the
Muhammad, can you put the slides again, please?
Okay, I will talk with about it without pointing. Okay, so the lungs are hyperinflated. There are several thick-walled dilated bronchi seen and done in keeping with ring shadows, which is bronchiectasis. There are also evidence of tram-line irregular bronchi in keeping with bronchiectasis, right-sided thorax. The pulmonary arteries are very prominent, indicating early pulmonary hypertension. And can you just put the ultrasound, please?
Doctor, if the heart is compressed a little bit?
Not really, no. It's just
No?
because of, it's just because of the pneumothorax and the condition which we are going to, Wafa is going to tell us what's the diagnosis. She has an excellent diagnosis. So the ultrasound, the liver and the kidney should be the same echogenicity. So the kidney is normal on this examination, normal. The liver is brighter in keeping with fatty infiltration. If we can see the pancreas, it will also have some fatty infiltration. Wafa, what is your diagnosis?
Cystic fibrosis.
Excellent, well done. Yes, this is cystic fibrosis.
Okay, thank you, Wafa. Now we are going to move to case number 6.
here?
Yes, you were called to see a baby in the postnatal ward, 50 hours old boy, born at term with abdominal distension, who did not pass meconium since birth. So this is abdominal X-ray for this patient. What are the findings? So regarding the findings, we have dilated bowel loops with absent air in the rectum. What is the next best investigation? It will be a barium enema. So we see here a part of stricture distally and proximal dilatation, which suggests area of absence of ganglions suggestive of Hirschsprung disease.
Very good. So the clinical examination is important. Like the first thing when this is, as I said, you cannot say what is large bowel, what is small bowel, but there is a dilated loops in the abdomen, more marked in the left lower quadrant. There is no air in the rectum. So the first thing we will ask if there is, if there's an anus, and I said if there's an anus, then we will do a barium examination or contrast examination. And contrast examination shows marked narrowing of the rectum compared to the sigmoid colon and proximal dilatation. So this is agangliatic segment secondary to Hirschsprung disease. Any association with any syndrome? Wafa, is it Wafa?
Down syndrome.
Seen in 10% of Down syndrome and other syndromes as well.
What the big syndrome?
Down syndrome, 10%.
Okay, Rehab, regarding room number 4, I think there was a technical problem in room number 4.
Yeah, apologies. There have been a technical issue in room.
Yes,
number
I can just go through them.
Or if anybody from room number 4 wants to
or
put
anyone
themselves
want to
forward,
volunteer and just comment.
yes.
Yeah.
and get the chance just to do it straight away with Dr. Inaam, just raise your hand if you would like to have this chance, please. Anybody from room number 4? Okay. So I think maybe if Inaam, if you want to go through this.
Yes, you can do this. If the moderator can please point, or the person who's showing the slides also help me to point.
Yeah, I'm here. I can read the questions and then help you with the pointing.
Yeah, okay. Can we have the X-ray, please? The CT scan.
Can we volunteer from?
Yeah, go ahead.
No,
Just, I read the question. Just
you read the
you
question.
are seeing a 12-year-old complaining of headache and blurred vision. On examination, swollen tender cranium and buggy swelling. What radiological investigation you will be doing urgently?
Will be CT, brain with contrast.
Yeah. So we have done CT of sinuses and the brain.
So there is complete obliteration of the left maxillary sinus, which is filled of fluids. And also maybe there is enlarged nasal tympanates. Not sure about other sinus involvement. I just see only the right maxillary sinus.
Yeah, okay, we'll give you another. Yeah, what is the next, please? Next slide.
Okay, there is soft tissue swelling in the scalp also.
Mm-hmm. What about the frontal sinus?
The frontal sinus, I think there is I don't know.
You're a radiologist, I can tell.
No.
No, you're doing really well. Okay.
Yes, I thought she's a radiologist as well, mashallah.
The way she described the sinuses was really good. So the frontal sinus is usually on top of the nose and front head. Okay, so can we show the next slides, please? Okay, so the front sinus is in front. If you can just point in front of the nose to the area with the gray tissue.
Yeah, I cannot.
You can see it. You can see it.
Yeah, it's clear, but I cannot point because
Maybe
I'm
Muhammad can
okay,
point.
then.
He's the one
yeah.
sharing. Muhammad, can you point?
Do you see my pointer?
I can see it, but it's not on the area.
Is it here?
Okay, don't worry. So there is opacification of the frontal sinus, and there is a gap in the sinus. Okay, can you see a break in the bone?
Yeah.
Okay, towards the head. And then if you look at the bone density, where the boggy swelling is, the bone texture is abnormal compared to the rest of the skull. If you just go back to the previous scan, and then you can see a collection of fluid, which is enhancing. This is done with contrast on top of the head. So this is sinusitis. Wafa, is it Wafa? Who's doing the case? But here, okay, what is your diagnosis?
Well, and I think this is a sinusitis complicated by either soft tissue cellulitis or abscess, soft tissue abscess.
Correct, yeah. It's an subdural emphysema, and osteomyelitis and an abscess, scalp abscess. And you can see where the infection got through from the sinus in the brain through that break in the front. Surgical treatment, yeah.
Very, very scary CT.
It's very scary, and it's scary he did not present earlier. This is a true case.
Yeah, I think.
Okay, thank you. So, Muhammad, can we move to case number 8?
Any volunteer for case number 8?
It's an easy one.
Yeah, just give it a go. Okay, so maybe Selma, do you want to read the Selma Amin? Do you want to read the case because you're in the moderator of that room, please?
Yeah, this is a 27-day-old admitted with a 3-day history of forceful vomiting, no bowel opening for 4 days. What's the diagnosis? Do you need to rule out? What diagnosis do you need to rule out? Sorry. So we did some investigations. Lactate was 3 and pH was 7.47 on admission. What further investigation would you like to do?
Sorry, 10 minutes to go.
So there is like a metabolic alkalosis in the blood gas with high lactate. And this is a boy with forceful vomiting. So I will ask for abdominal ultrasound scan to exclude congenital hypertrophic caloric stenosis.
Very good. Mm-hmm.
I can see there is like a thick pylorus, as I can see in the ultrasound scan. We have some measurement.
Yeah.
So there's thickening of the muscles of the pylorus. Yeah.
Yeah. Well done. So,
we need physical
yeah.
intervention.
Yeah. So this is his 27, and just remember, some premature babies will present earlier than full term. So usually in the literature will say 6 to 8 weeks. And this is the real case. He was 27 years old with a family history of pyloric stenosis. So the family knew exactly, you know, what to do. So they came to the hospital. We usually give them a feed or a fluid or a bottle of milk before do the examination. It calms them down. It distends the stomach. You can see on the first picture to your of the screen, to the left of the screen, there is fluid in the stomach. We have measured the pylorus. It is about 13 millimeter. Not as long as, in the full term usually is longer than that, but the preterm we allow for 15, 13 millimeter. Pyloric wall thickness is 5 millimeter. We don't like to see more than 3 millimeter. And in addition, when we give them the meal or the fluid, it is a dynamic examination. So if the fluid goes through the pylorus, it's a spasm. We keep watching for the thickness if it changes on and off. But if it's persistent thickening with no gastric emptying, this is pyloric stenosis. Thank you. Well done. Thank you. Rehab, am I allowed to put my last question?
Yes, please.
Yes,
You
sure.
You have like 8 minutes.
Sure, go ahead, please.
Okay, I have one more last question for everyone. I think you are sharing it, يا رحاب, مش كده؟
Is it?
No.
Is it the poll question, Inaam?
Yes,
Do you want me
yes,
to poll?
yes, please. Yeah, yeah.
Okay. So you will get a poll question, and I'll be sharing the X-ray soon with it. So have a look at the X-ray.
Yeah, this is for everyone. Can we see the X-rays and the image, please?
Yes, 1 minute, please. Can you see the X-ray?
Yeah, and you know, can you put them side by side? No, there's another image. No, can you split your screen? No. Okay, put the first. Yeah, put the first image first, please. The demonstrator.
The other one. Okay.
Can you put the actual image?
Can you see it now?
Yes, yes. of course, peaceful demonstration have been going in our beloved Sudan for several years now. A lot of demonstration are peaceful. They are just catching bomban and stones and throwing them at the army forces and the militia forces, and they are getting killed for no good reason. A few of them have developed spontaneous fractures of the humeri. Can you please show the X-ray? So this is one of the X-ray. You can see the epiphysis of the olecranon hasn't healed. So this is not even an 18 years old peaceful demonstrator presented after the demonstration to the X-ray, to the radiology emergency department with this fracture. What are the causes of this fracture? To the emergency department with painful hand, they got an X-ray and there is a fracture of the humerus. And I'm going to give you 4 options. Rehab is going to give 4 options for the possibilities.
I think the poll is already there. Everybody.
Yes, I can see it.
Yeah. So we'll give it.
Can you please share it again because I close it?
What do you want to see? The X-ray?
The X-ray. The X-ray.
Yeah. Okay.
The options for the question disappeared.
The options are: is this the secret weapon used by the security and militia forces, underlying bony lesion, metabolic abnormality, or repetitive strain injury fracture, which is also called ball thrower fractures?
The last one, I think.
And just tell me when you want me to end the.
Okay. Has everyone participated? Are we ready?
Yeah, 50, 91%. Yeah, I think almost everybody has.
Okay, then good. Yes. Yeah, there were a lot of theories about this, and people that were saying the Janjaweed got some Russian weapon. And actually, I went to an excellent talk by a young Sudanese radiologist in Newcastle, and he showed he is actively participating in diagnosis of the acute injuries in most of the demonstrators who attend the hospitals. And this is a repetitive strain injury in ball throwers. It is seen also in athletes who throw baseball or tennis ball, especially in the young athlete before their their muscles have developed to protect the elbows and the joints. So this is repetitive strain injury. Luckily, it's normally not associated with radial nerve injury, and it can be treated without residual complications. Thank you.
Thank you very much, Inaam. Do you have any question? We have 2 minutes left. Anyone want to share anything or to ask Inaam?
Yeah, I just want to ask a very, very basic question about the X-ray. When we say like hyperinflated chest, is there like specific criteria? And is it depend on the like how many reps? Like I know in neonates, like maybe 8-9 reps is okay, but I'm not sure about the different age group in
there are anterior and posterior. So because the children's, the X-rays are usually taken without them being able to hold his breath. You don't know if it's taken inspiration or expiration. In general, I go with the anterior ribs. If the anterior ribs are less than 5, so this is like poor inspiratory effort. For some reason, it was taken on expiration. If I see more than 7 ribs anterior, then it's hyperinflated.
This is for all age groups, right? Or
for most age groups, it's difficult if the child cannot follow breathing instructions. I will go with 5 to 7. It's very difficult in the neonates unless you see like flattening of the diaphragms and things like that. Neonates, seriously, you just have to go by the clinical picture. Chest X-ray is not very accurate.
Yeah, please answer.
Okay, thank you. If anybody want to ask any question before we close.
أخبار الكورة شنو؟
المغرب 1-0.
Woo!
يا سلام.
This is the best ending. I would like to say thank you to the الجمعية الطبية السودانية for inviting me to give this talk. I hope you found it useful. I would like to give sincere thank you to Rehab for chasing me nicely and make sure I do this on time. Thank you so much.
Thank you very much, Inaam. It was excellent presentation and excellent presenter. And I think everybody got the benefit of this session. And I hope we will meet you again.
Inshallah.
And thank you, everyone. Inshallah. Thank you, everyone.
Thank you so much.
Yeah, thank you very much, Inaam. I think this has been an
you.
amazing session, especially for pediatricians. I think radiology is always our...
Yeah.
So everybody, if you can please...
Yeah, I just like to reminder, okay, please fill out the feedback form that was we have dropped in the chat box, which is linked to your certificate. Please allow a period of couple of weeks for issuing them. And before we leave, I would like to make an announcement, please, regarding the next upcoming events. We have another 2 projects, Keep Me Safe and Bravo Award. Please, for more details about them, visit our website for the news and activities page. And if you live in UK or Republic of Ireland, interested in the field of child health, and would you like to become one of BSAPCH member, please visit our website on the Become a Member page, which is www.bsapch.co.uk become-a-member-2. And if you need any assistance in the process of your application, please contact us on info@bsapch.co.uk, and our membership and treasury secretary and officer will be more than happy to help you. Thank you, everyone, again for participating in this session, and we hope that we'll meet again. Thank you very much and have a nice evening.
Thank you.
So some were asking about the recording. It's already, this session has been live streamed in Facebook, so that will be readily available on our Facebook page. It will be also soon uploaded on our YouTube channel as well as website. So I think we managed to finish on time, alhamdulillah. So thank you very much, and hope to see you soon in next sessions. So feel free to leave if you have done the feedback, and please, if the moderators and speaker, if we can just
Excuse
have
me, I just have last one question. Sorry for this late question. Just regarding the X-ray for the patient with cystic fibrosis, is it BA view or AB view? Because I think it looks a little bit strange.
I don't know if Inaam is around.
It looks like Inaam left.
Yeah. I think Inaam has left. We can send her your question by an email and get back to you.
Thank you very much. Thank you.
Okay.
Thank you.
Okay. So please, just the moderators, if you can stay for a few seconds.